Opportunity to present today on the topic of methadone and buprenorphine in patients with HIV. Before we begin the formal part of the presentation, there's just a few housekeeping issues that I would like to go over. The first one is the financial disclaimers for this presentation. I have no current or ongoing pharmaceutical company funding. However, in the past I have received a $1,000 bursary from Reckitt Benckiser in order to develop a teaching module for buprenorphine naltrexone for prescribing physicians. An additional disclaimer that I think is important is that while we're hopefully going to spend a lot of this talk today talking about ways that we can improve the management of this challenging patient population, I think it's important that I acknowledge right off the bat that this is certainly one of the hardest areas of practice that I encounter in my day-to-day clinical work, and that I certainly would not want to give anybody the impression that I'm claiming in my presentation here to have all the answers or that this is simple or easy. It certainly isn't, and that if any of us find this work challenging, I just want to acknowledge the fact that that's the case for me as well, and that the purpose of this presentation really is to hopefully improve our understanding rather than give people a simplistic right answer to these difficult and challenging cases. I'd also like to just acknowledge my affiliations. So I am an addiction consultant with the Casey House AIDS Hospice and with St. Michael's Hospital, as well as the lead editor of the American Society of Addiction Medicine textbook entitled Principles of Addiction Medicine, The Essentials. I'm also an assistant professor in the Department of Family and Community Medicine at the University of Toronto and the medical director for the True North Medical Center methadone buprenorphine program. And that slide says the same stuff. So, goals and learning objectives for this talk today. The primary goal for today is to examine some of the unique challenges and opportunities in managing patients with HIV who are on opioid agonist substitution treatment with either methadone or with buprenorphine. In developing this talk, I spent some time reflecting on my practice, and I identified three key areas where my HIV opioid dependence practice differed from the practice where I have patients with either just opioid dependence or just HIV. And I also wanted to think about some cases where the pharmacist played a key role in terms of improving the care for these challenging patients. The three key areas where I thought that my practice differed significantly was that, generally speaking, in the population with both HIV and opioid dependence, I tend to use a lot more twice daily or 3 times daily dosing. I also tend to use direct observed therapy, or DOT, far more often, and I also tend to use the Metadol formulation of methadone far more often than I do in the regular opioid dependence population. So, keeping those three areas in mind, the goals and learning objectives for the talk today are to understand and appreciate the impact of HIV illness on methadone and buprenorphine treatment, as well as the impact of the HIV medications themselves on methadone and buprenorphine treatment. Also to understand the opportunities for direct observed therapy in this patient population, and the use of methadone and buprenorphine in the palliative HIV setting. Finally, I would also like to discuss the use of methadone and buprenorphine in the HIV neuropathy setting. In meeting these goals and learning objectives, we'll be using a case-based approach, and the cases developed for inclusion in this presentation included the following criteria. Cases must highlight issues concerning both HIV illness and opioid use. The cases must address one or more of the 5 learning objectives in the previous slide, and the cases must involve the pharmacist playing a key role in optimizing the care of these patients. So, with all that housekeeping out of the way, let's move on to the cases themselves. So our cases are going to involve a few key players, and we'll just review who they are. So the first key player is Mr. Neo, and Mr. Neo is an HIV positive patient who is also opioid dependent. Our second key player is Penelope Herrera Moretti, or PHM for short. Penelope is the pharmacist looking after Mr. Neo. Our third key player is Dr. Horatio Ignatius Vivaldi, or Dr. HIV for short. Dr. HIV has a large HIV practice and is by all accounts, an excellent HIV doctor. As with most HIV primary care doctors in Ontario, his practice has a large number of HIV patients, and HIV care in Toronto and in Ontario tends to be done by a small but very dedicated group of doctors who tend to have large HIV practices. And this isn't surprising. In fact, the research actually tells us that doctors who have more experience in managing HIV tend to have better prognosis amongst their patients. So their patients tend to live longer and live better. But Dr. HIV does have a blind spot. It's worth us keeping in mind that up until about 10 years ago, an era typically defined as the pre-HAART or highly active antiretroviral treatment era, the options available for HIV were quite limited. And during this era, the focus amongst practitioners was on keeping patients comfortable, which often needed to include the use of lots of opioids because of all of the pain issues that these patients experienced. And many of the patients we continue to see at St. Michael's Hospital and at Casey House, where I work, contracted HIV during this era. And many of the HIV service providers, including, in our case, Dr. HIV, began treating patients in this era. Our fourth key player is Dr. Othello Alfonso Sergio Tarantino, or Dr. OAST for short. And Dr. OAST is one of a small group of doctors in Ontario who provides opioid agonist substitution treatment, or OAST, with methadone and buprenorphine. It's worth us keeping in mind that there's approximately 30,000 practicing physicians in Ontario, but only about 300, or 1% of whom, actually have methadone licenses. So again, we're talking about a relatively small group of doctors who have a lot of familiarity with this form of treatment. And as with Dr. HIV, Dr. OAST also has a blind spot. While he does know a lot about managing patients with methadone and buprenorphine, he is really not that aware of the impact of HIV illness and HIV medications on the treatment that he's providing. And also, while Dr. OAST knows a great deal about managing opioid dependence, he's much less familiar with the use of opioids within a pain context, so for the use of opioids in pain management. So now that we've reviewed who our key players are going to be for our cases, let's review a couple of the key concepts that we're going to go over. So one of the things I mentioned right at the beginning was that I tend to use a lot more twice a day or 3 times a day dosing, or BID or TID dosing, within the HIV context. And I'd like to kind of explain the reason for that. It has to do with the fact that within the HIV context, the therapeutic window for the management with methadone and buprenorphine So now that we've reviewed who our key players are going to be for our cases, let's review a couple of the key concepts that we're going to go over. So one of the things I mentioned right at the beginning was that I tend to use a lot more twice a day or 3 times a day dosing, or BID or TID dosing, within the HIV context. And I'd like to kind of explain the reason for that. It has to do with the fact that within the HIV context, the therapeutic window for the management with methadone and buprenorphine tends to be a lot narrower than it is in other patients. And so when I use twice daily or 3 times daily dosing, it's because of this issue with a narrow therapeutic window, and it's not necessarily for pain per se, as I'm going to explain in some of the cases that we're going to go over. So let's talk about case number 1. Mr. Neo is on methadone with Dr. OAST. The pharmacist, Ms. PHM, gets a call from Dr. HIV. He's not clear if Mr. Neo is on methadone, quote, for pain or, quote, for addiction. Here's the inspiration for this case. So in preparing for this talk, I took a look at the Ontario Pharmacists Association methadone forum and came across this quote, which I think is an issue that often comes up in terms of the care providers for a patient trying to figure out exactly what the reason is that a patient is on twice daily or 3 times daily dosing. So I have long suspected, just by looking at the dosing patterns and past narcotic use, that some of our patients were being treated as if it was for addiction, but told it was for pain control or vice versa. Just to review, this I think was my perspective at the beginning of my career as a methadone and buprenorphine prescribing doctor. So I tended to view things in a very sort of binary way. Patients either had pain issues, in which case methadone and buprenorphine were probably not appropriate options, or they had addiction issues, in which case methadone and buprenorphine were appropriate options. And then, until more recently, I think my perspective tended to look more like this kind of spectrum approach to evaluating this issue, with some patients drifting more towards the pain end of the spectrum and some patients drifting more towards the addiction end of the spectrum, and some being somewhere in between. But I think this is my perspective now, where there are some patients who have chronic pain, there are some patients who have opioid dependence, there are some people who have opioid-related complications that don't necessarily fit criteria for chronic pain or opioid dependence, and that methadone and buprenorphine can often have a role in managing all 3 of those types of situations. I think my perspective differs a little bit from that of the College of Physicians and Surgeons, so I would like to just review the way they approach this issue. What they say is that patients should really be divided into 3 groups. Group 1 is patients with no identified risk factors for opioid dependence beyond that found in the general population. Group 2 are patients with a past history or active history of non-opioid related problems, but with some kind of substance dependence. So not opioid dependence, but some other kind of substance dependence. And then group 3 are patients with active ongoing opioid dependence. And what the college recommends is that group 3 should certainly be treated with guidelines that adhere as closely as possible to those recommended for methadone maintenance treatment within an opioid dependence context. But I think there's some problems with the CPSO approach, and this is a quote from an article by Dr. Doug Gorley, who is a pain and addiction doctor in Toronto, and I have to say I very much agree with his approach, as he points out that it is unfortunately very difficult, particularly early on in treating a patient, to determine with any degree of certainty who will become problematic users of opioid medications. And so based on this, his argument is that it's best to adopt a universal precautions type of approach. So in much the same way that it is safest to assume that every single patient that we treat in a health setting potentially has a bloodborne disease and that we should take precautions accordingly, it's safest to assume that everyone can potentially develop problematic use of their opioids and to take precautions appropriately. So in other words, it's better to start with tight boundaries and make sure that you're keeping patients safe than it is to assume that every single patient is going to be able to manage their use of opioids safely, and only to discover later that some of those patients are not using their medications in a safe and non-problematic fashion. keeping some of those concepts in mind, what I'd like to talk about is how the issue of pain can cause a narrowing of the therapeutic window and why that might lead to the need for patients to have twice daily or 3 times daily dosing of their methadone. So let's just review. This is a fairly standard patient with opioid dependence with no pain issues. So as we can see in this slide, the patient begins the day. This is a 24-hour timeline that we're looking at here. So the patient begins the day with a relatively low level of methadone in their system, and then they take their methadone dose, and then it's going to go up over the first 2 to 3 hours of the course of that day, and then it's going to slowly drift down over the rest of the 24 hours. But they're going to spend their entire day within that therapeutic window. So they're not going to be in withdrawal and they're not going to be in intoxication. Now, this is a typical patient with chronic pain who's on once daily dosing. As you can see now, this patient needs a certain amount of medication simply to keep them out of withdrawal. But now on top of that amount of medication, they need an additional amount of medication to keep them out of pain. This leads to a narrowing of the therapeutic window. So the amount that they need to experience intoxication, overdose, or death really hasn't changed very much. But now what we have is the challenge of needing to keep the dose within a very, very narrow range. If it goes below that, the patient experiences pain. If it goes above that, they start to experience intoxication. It's going to be hard with once daily dosing to keep that patient within that therapeutic range for the entire day. So the solution under those circumstances is to switch this patient to TID, or 3 times daily dosing. As you can see, what that allows us to do is keep the dose high enough that they don't go into pain, but below the point where they would actually experience intoxication. So it allows us to keep the dose within a much narrower therapeutic range in cases where the therapeutic window is not as large as it is in patients who just have to deal with withdrawal, as opposed to patients who have to deal with both withdrawal and pain. So that's one example of why it is that I might use BID and TID dosing more often in HIV patients, because a lot of them do have chronic pain issues. But another reason why I often have to use BID and TID dosing in my HIV patients is that many of them also have comorbid illnesses, and I'd like to explain why that might also lead me to make a decision to split a patient's dose. So again, let's just review. This is the standard curve for a patient just with opioid dependence, not with any kind of pain issues, not with any comorbid illness issues. This is now a patient with some other comorbid illnesses on top of their HIV. So this is actually a real case from my practice. This is a patient with really, really end-stage COPD as well as HIV. And the challenge in his case is that even very, very minor changes in his respiratory rate and respiratory status, which can occur with opioids, tends to, in his case, cause him to develop oxygen desaturations, and that tends to lead to changes in his level of consciousness. And this is a patient of mine who is getting admitted to the emergency department at St. Michael's Hospital on a very, very regular basis, often as much as 2 or 3 times a month, because of changes in his level of consciousness due to decreased oxygen saturation. So the problem in this patient's case is that he needs to have a certain amount of opioids in his system to keep him out of withdrawal, and in fact in this patient's case he also does have some pain issues as well. But if we increase his dose too much, it doesn't take very, very much to decrease his respiratory rate to the point where he becomes intoxicated from his opioid dose. So the solution in this case, again, was to switch him from once daily dosing to 3 times daily dosing. And once we did that with him, he tended to experience much fewer episodes of oxygen desaturation and has actually done much, much better. So he's gone from 2 or 3 times monthly admissions to St. Michael's Hospital for decreased level of consciousness to the point now where it still does happen, but it's down to probably once every 3-4 months that's happening for him now. Here's another example of why I use a lot more BID and TID dosing in my HIV patients. This is a case where a patient has a normal therapeutic window but has rapid metabolism of their methadone dose. So I'd like to illustrate that particular concept using a case. So this is actually from a case in my office. Ms. PHM, the pharmacist, gets a call from Dr. OAST. Mr. Neo has told him that he started on a new antiretroviral or ARV regimen called ATRIPLA. Dr. OAST doesn't know a lot about ATRIPLA and wants to know if this regimen will in any way interact with the methadone that Dr. OAST is prescribing. Well, to answer that question, there's actually a fairly database that we can use. This is called the HIV Insight database, and it basically lists the interactions between antiretroviral medications and other medications. So here's actually what I did for this presentation to answer this question. This is actually a screenshot that I took when I was doing the review for myself. So I basically went to that website and I typed in methadone, which also goes under the names Adolafine and Dolphine, and I hit submit, and then this is what I came up with. So the 3 medications that are in ATRIPLA are efavirenz, tenofovir, and emtricitabine. And of those 3, the one that's most important for our purposes is efavirenz. As it mentions on the HIV Insight database, study patients required a mean dosage increase of 30% over a period of 60 weeks. So patients who were on efavirenz as well as methadone for a 60-week period required on average about a 1/3 dosage increase in their methadone. With both tenofovir and emtricitabine, there wasn't really any major change in the dose that was necessary. So let's review what impact that might have again. So just to review, this is the therapeutic window for a typical patient with opioid dependence. So no pain issues, not on a medication that causes rapid metabolism or other changes. This is a patient, that same patient who has now been started on a new medication like efavirenz that alters how quickly methadone is metabolized. What we can see in this slide is that the slope is much steeper, that the methadone leaves the system more quickly. And so that before the 24-hour period is up, this patient is already starting to experience withdrawal. But the challenge is we can't simply increase this patient's dose to make the dose last longer, because if we do, this patient will start to experience intoxication. So the solution under this case is to split this patient's dose. And often in this type of context, we'll often use twice daily dosing, where patients receive 2/3 of their dose in the morning and then 1/3 of their dose in the evening. And what this allows us to do is to keep the patient from getting too much dose all at once so that they would get intoxicated, but also by splitting the dose, we give them a second peak later in the day that allows them to increase their methadone level back up a little bit and allow it to slowly drift down over the course of the evening so that they don't go into withdrawal. So those are 3 examples of cases in which I might use twice daily or times daily dosing, and you can see how those types of situations might come up more commonly in my HIV patients than they would in my general patient population. Key concept number 2 is that these drugs may have a unique role to play in treating HIV patients on high-dose opioids and or neuropathic pain, and I'd like to explain why that might be true, why it is that methadone and buprenorphine might have a unique role relative to other opioids in treating HIV patients who are on high doses of opioids or neuropathic pain. Here's a case that will hopefully illustrate some of that. Mr. Neal mentioned to his team that his HIV neuropathy has been much better controlled since switching from other opioids to methadone, and he is wondering what might account for this. There's a number of reasons why it is that methadone might have a better role to play in managing pain, particularly neuropathic pain, compared with other opioids. One of those reasons is that it's very clear that methadone activates NMDA receptors far more than other opioids do, and that in fact the morphine concentrations that are required to have the same impact at NMDA as methadone, it requires about 6 to 18 times the same concentration of morphine compared with methadone to achieve the same NMDA effect. And by blocking NMDA, methadone can significantly reduce pain, particularly neuropathic pain, which may also help. And NMDA has also been demonstrated to be quite important in terms of the development of opioid tolerance, and the fact that methadone has an antagonist effect at NMDA may also help prevent the development of tolerance, so it allows patients to stay on lower doses for longer. This is an interesting test that illustrates some of these concepts. This is a test called the cold pressor. There's a number of reasons why it is that methadone might have a better role to play in managing pain, particularly neuropathic pain, compared with other opioids. One of those reasons is that it's very clear that methadone activates NMDA receptors far more than other opioids do, and that in fact the morphine concentrations that are required to have the same impact at NMDA as methadone, it requires about 6 to 18 times the same concentration of morphine compared with methadone to achieve the same NMDA effect. And by blocking NMDA, methadone can significantly reduce pain, particularly neuropathic pain, which may also help. And NMDA has also been demonstrated to be quite important in terms of the development of opioid tolerance, and the fact that methadone has an antagonist effect at NMDA may also help prevent the development of tolerance, so it allows patients to stay on lower doses for longer. This is an interesting test that illustrates some of these concepts. This is a test called the cold pressor test. Here's how it works. What you do is you get a patient to put their hand in a bucket of ice water and to hold it there for as long as they can. And by measuring how long they can hold their hand in the water, that gives you some sense as to what their pain threshold is. I don't think it would surprise many of us to discover that if you take a patient who is not given opioids on a regular basis, but you give them an opioid on the day that they do this test, that they're going to do very well on this test. It's going to raise their pain threshold. They're going to be able to keep their hand in that bucket of ice water for a long time. So that's the top left-hand corner of that of those 4 quadrants. If you take a look at the bottom right-hand quadrant, I don't think, again, it would surprise many of us to discover that a patient who is on chronic opioids, who is not given their opioid on the morning of the test, is not going to do very well on this test, that's actually going to lower their pain threshold. But I think the 2 quadrants that maybe do surprise people are that if you take a look at the quadrant on the top right-hand side, which is a patient who is on chronic opioids and is given their opioid, their regular opioid dose on the day of the test, they don't do as well on a cold pressor test as a patient who is not on opioids and is not given an opioid on the day of that test. In other words, a patient who is on chronic opioids and is given their regular opioid dose may actually not do particularly well in terms of pain thresholds. And the following slides will hopefully explain more about why that might be. I just reviewed this, but just to say it one more time. So chronic opioid users can have lower pain thresholds than patients, even when they're given their regular dose of medication, compared with patients that don't regularly take opioids. This is a concept called opioid-induced hyperalgesia, and it tends to happen a lot more often with short-acting high-potency opioids than it does with opioids like methadone or buprenorphine, which have much longer half-lives. And this is some of the concepts that might explain that. A bit of historical context might be useful here. So this is the gate theory that was developed back in 1965. It was published in Science, and the general concept here is that we have a gate that can be relatively open or relatively closed, and the more open the gate is, the more pain we experience. The more closed the gate is, the less pain we experience. And the ascending signals that go from the nerve ending up towards that gate tend to open the gate up. But we also have descending signals that go from the brain down the spinal cord, so central nervous system signals that actually inhibit the opening of that gate. So they keep the gate closed. So we have CNS inhibition keeping the gate closed, and then we have pain fibers trying to open that gate. And the more open the gate is, the more pain we experience. Now, let's take a patient who was experiencing some pain and then is given an opioid. So here's what basically happens. In that case, the blue arrows on this slide are exact size that they were on the previous slide. So what we see is that the amount of ascending signals, the amount of pain signals going up, are exactly the same. The amount of central nervous system inhibition is exactly the same, but now what you've got is that red arrow going down, which is the effect of the opioid itself, which works at the brain level to keep the gate closed. So that red arrow going down and that blue arrow going down are bigger now than the blue arrow going up, and that basically means the gate is going to stay relatively more closed and the patient is going to experience relatively less pain. But the problem is that over the course of 2, 3, 4 months, the brain tends to adapt to the presence of opioids, and that's referred to as neuroadaptation. So there's a number of brain changes that happen, including opioid receptor downregulation and other changes in the brain that basically make the opioid less effective, and that also have an impact on the level of central nervous system inhibition that happens. So what that basically means is that those two descending arrows get smaller. So the amount of opioid effect becomes less and the amount of central nervous system inhibition becomes less, but the amount of pain signals going up haven't changed at all. So basically what can happen is that over time, those two descending arrows are actually smaller than the original central nervous system inhibition arrow was before a patient went on opioids, and that's referred to as opioid-induced hyperalgesia. But here's the most difficult part about managing opioid-induced hyperalgesia. Suppose you've got a patient in your practice and you realize that that's what's going on with this patient, that despite the fact that you're going higher and higher on this patient's opioids, they're experiencing more and more pain, and you're trying to persuade that patient to stop their opioids. Well, they were still getting a little bit of impact from the opioid effect, and now what you're going to do is you're going to take that away. And even when you take that away, it's not like the brain immediately reverts back to the way that it was before. That often takes weeks or months to happen. And during that time, this patient will only have that tiny little CNS inhibition arrow keeping the gate closed. So you actually have to make the pain worse before you can make it better. And that's a really, really tough thing to convince a patient to try and do. And it's one of the reasons why, as I said right at the beginning, I think it's important that we acknowledge how difficult and challenging this type of care can be, because often we have to convince patients to feel worse before we can start to make them feel better again. This is just another way of looking at this issue of neuroadaptation. This is a patient on a TID, short-acting high-potency opioid. So this is a patient who's taking a short-acting high-potency opioid on a 3 times a day basis. And the key point here is that it's these boluses of opioid all hitting the brain at once that tend to cause the neuroadaptation that happens. So it's when a whole bunch of opioid molecules all hit the brain simultaneously. That's what leads to things like opioid receptor downregulation. So the more that you have these big peaks and these big valleys, the more neuroadaptation happens in the brain. And this is what happens over time as more and more neuroadaptation happens. So this is a patient who has now been on opioids for 3 months and is now on is still on TID dosing. So their therapeutic window has gotten narrower and narrower, so they need more and more medication now just to keep them out of withdrawal, and more medication to control their pain. But what we know is that the level of the drug that will cause intoxication, overdose, and death doesn't tend to go up nearly as much as the pain and withdrawal part of the dosage graph. In other words, you get a narrowing again of the therapeutic window. And here's what happens though when you start to switch a patient like that onto methadone or buprenorphine. What we see is that therapeutic window starts to open back up again, and the dose remains much steadier, that the neuroadaptation begins to normalize again, and that the level of the drug in the body tends to stay a lot more steady, and that the brain can start to heal. Just kind of one more final analogy to explain why it is that switching patients onto a medication like methadone or buprenorphine can often be very effective in terms of managing some of these neuroadaptation issues. So let's take a look at the analogy of patients with alcohol dependence. So we know that patients with alcohol dependence can have seizures even when their alcohol level is really high, even levels that would be toxic in patients who weren't alcohol dependent. And so why does that occur? Well, the theory is that because the level of neuroadaptations in the brain in individuals with alcohol dependence are so severe, all it takes is very small drops in the blood alcohol level to cause aberrant firing of the nerve fibers in those patients' brains to lead to a seizure. And how is that treated? Well, what we do is we give those individuals diazepam in the emergency department. And why do we do that? Well, it's because diazepam is a very long-acting GABA agonist. Alcohol itself is a GABA agonist, but it doesn't last nearly as long as diazepam does. So by loading patients up with a long-acting GABA agonist like diazepam, what it allows to happen is that the drug, the diazepam, dissipates from the system far more slowly and allows for those neuroadaptive changes to revert back to normal far more slowly, and that this reduces the risk of the type of aberrant nerve firing that leads to a seizure. So using that analogy, we know that individuals with opioid dependence can have significant pain at high, even toxic blood opioid levels. And why should that occur? Well, I think for much the same reason, which is because the level of neuroadaptation that's happened in their brain is so severe that even small drops in their blood opioid levels can cause aberrant nerve firing that results in pain. And using the same analogy that we used in the previous slide, what we can do in individuals like this is give them a much longer acting opioid agonist that allows for those neuroadaptive changes to revert back to normal much more slowly, and that this can also reduce the risk of the type of aberrant nerve firing that results in pain. The next key concept that I'd like to discuss is the fact that opioid agonist treatment can often be very effective in improving medication compliance in HIV patients. And here's a case that illustrates that. So Dr. HIV and Dr. OAST have both noticed that Mr. Neal almost always takes his methadone each day. However, he almost never takes his antiretroviral medications. And they're wondering if Ms. PHM has any suggestions on increasing Mr. Neal's antiretroviral adherence. This brings up a concept called direct observed therapy, or DOT. And there are numerous studies, including the Conway study from 2004, the Lucas study from 2006, and the Tran study from 2012, that have demonstrated that direct observed therapy of HIV medications, particularly within an opioid treatment context can be very, very effective. So basically what this approach means is that the pharmacist witnesses and supports patients in taking their HIV medications along with their methadone or buprenorphine doses. It obviously works best if patients are on once daily dosing of their HIV medications, but fortunately there are an increasing number of HIV medications that can now be dosed once daily. The next key concept that I'd like to discuss is the fact that I mentioned at the beginning that I tend to use a lot more of the Metadol formulation of methadone in my HIV patients than I do in my regular patient population. And this is because in my particular case, I do have an exemption for methadone for pain and an exemption for methadone for addiction. And I'd like to illustrate this using a case. So despite everyone's best efforts, Mr. Neo's health continues to deteriorate and he is now palliative. Dr. HIV would like to transfer Mr. Neo to Casey House. He calls Ms. PHM to find out if it might be possible to switch Mr. Neo to the Metadol, which is the pain formulation of methadone. As we've talked about already, if you're trying to figure out whether or not you should be asking about whether or not a doctor has, whether or not the exemption that's important is a pain versus addiction exemption, these things can sometimes be helpful, but not always. So if a patient is on methadone, even BID or TID, they may have pain, they may have addiction, or they may have both. But generally speaking, if the patient is on Metadol, they have pain, they potentially might have pain and addiction, but generally speaking, they cannot have only addiction, that nobody would be using the Metadol formulation strictly for addiction, that if they're on Metadol, that generally means they have some sort of pain issue. In terms of accessing the Metadol formulation of methadone, there's a program called the Exceptional Access Program, or EAP program, that facilitates the access of drugs not generally funded under the ODB or Ontario Drug Benefit Formulary. And if a physician completes the EAP application process, they can actually access additional drugs that are not generally on the formulary, such as Metadol. Here's how the process works. So there's a few different ways doctors can try and get access to these medications. They can submit the standard form, or they can also call something called the telephone request service, which assesses requests in real time for selected drugs only. And there's a link to the website that provides more information on the EAP process. So here's the EAP reimbursement criteria for Metadol. So if you're filling out the form, then you need to indicate that you are using Metadol for the treatment of cancer or non-cancer pain in patients who cannot tolerate or have failed treatment with a long-acting opioid. So if you put down on the EAP form that you're using it under these circumstances, the EAP program will approve it. And the standard duration of approval in situations like this is 1 year. In terms of phoning the telephone request service, the criteria are more strict. So in that situation, it can only be used for patients who are receiving palliative care, and the telephone request service will only approve it if it is being used to control pain or in patients who have intractable side effects to other narcotic analgesics. And the standard duration for approval through the TRS service is 6 months. This is just a slide showing an example of the EAP form itself, and if anybody wants a copy of that form, the link is there on the bottom right. There's one additional way of being able to get access to Metadol within the palliative care context. So selected doctors can also apply to become part of what's called the Palliative Care Facilitated Access List, or the PFCA, and in order to use Metadol within this context, the patient eligibility criteria are that patients must have a terminal illness and that they have chosen outpatient palliative treatment and that they have a life expectancy of less than 6 months. And again, the period of approval in these situations is 6 months or less. here's basically the criteria for a doctor to apply to become a doctor on the palliative care facilitated access list. So basically what a doctor has to do is contact Ina Nesbitt at the Ontario Medical Association. Her telephone number and the email address for Ina Nesbitt are on the slide here. And in order to apply, the doctor has to meet the criteria listed above. So more than 20 palliative care consults in a year or 50 palliative care visits in a year. So 20 separate patients or 50 palliative care visits in a year, as well as some additional criteria listed there. It's also worth knowing what the criteria are to obtain Metadol within or through the Non-Insured Health Benefits, or NIHB program, which is the program for First Nations and individuals of Inuit status. So for them, the criteria are that clients must have either moderate or severe cancer pain or chronic pain and have tried 2 other opioid pain relievers before trying methadone, and they also will approve it if it is being used to manage end-of-life pain, and the duration of approval in these circumstances is for 30 days. The next key concept that I'd like to discuss is the idea that because of the challenges of managing patients with comorbid illnesses and some of the other challenges that we've talked about, that these are patients who are best managed within a multidisciplinary context. And I'd just like to share this case. So Dr. HIV calls Ms. PHM to notify her that Mr. Neo has passed away. Dr. HIV mentions that he has noticed that while only 10% of his patients are opioid dependent, almost 70% of his HIV patients that get admitted to Casey House or to the hospital have serious addiction issues. He's wondering why it is that his HIV patients with opioid dependence do so much worse than his other opioid dependence patients. And there's a number of reasons that likely account for that. One is, what the studies tell us, is that patients with HIV and opioid dependence tend, when compared with just patients with HIV without opioid dependence or other addiction issues, those patients with addiction issues and HIV tend to present a lot later in the course of their illness. They tend to have higher viral loads and lower CD4 counts when they present. They tend to respond less well to HIV treatment. They are more likely to have comorbid illnesses such as hepatitis C. They require far more frequent admissions to the hospital. They're more likely to get AIDS-defining illnesses, and they're more likely at the end of the day to die. So these patients tend to be a lot more complex than the general patient population are, and I think that really highlights why it is that the pharmacists can often play such a key role in terms of helping to manage these patients. So some of you may have already heard, kind of seen this this analogy before, but this is that's a slide, the elephant there with six blind doctors in this case. So one of the doctors thinks that he's touching a snake, and then the second blind doctor thinks that he's touching a spear, and then the third blind doctor thinks he's touching a column, and one thinks he's touching a fan, and another one thinks he's touching a wall, and one thinks he's touching a rope. And often it's the pharmacist. The pharmacist is often the one that really knows what's going on, that really what we're dealing with here is an elephant. And there was actually just a case the other week in my practice that I think really illustrates this concept. There was a patient of mine with HIV illness and opioid dependence who recently switched to our pharmacy, and we discovered that this was actually a patient who'd been receiving large doses of other opioids from his HIV primary care doctor, as well as methadone from his methadone doctor. And in speaking to those 2 doctors, neither one of them was actually aware of what the other doctor was doing. And when we spoke to the prior pharmacist, what he'd said was, well, I spoke to the patient about it, and he said that he'd informed both of his doctors about that. But in fact, the patient was actually very worried about his 2 doctors finding out about what the other doctor was up to, and so had actually not disclosed to either of them what was really going on under those circumstances. And I think it illustrates how important and key the pharmacist can actually be in terms of ensuring that everybody knows what's actually going on with the patient, that they're often the ones who have the best idea of the various medications that a patient's taking, and often they're the ones who see the patient most often. If I have a patient who's on daily dispensing of their methadone, then the health provider that they see the most often and who probably has the best idea of what's going on in that patient's life is often the pharmacist. So, with that said, I would just like to acknowledge the pharmacy team that I work with on a daily basis, and who play such a key role in terms of managing the patients that I work with. So just thank you to all of them. And thank you to all of you in the audience for bearing with me through the presentation. I hope it was helpful. And that's the end of my cheerleading session for today. So thanks very much to all of you.